Good morning, good afternoon, good evening. Peri Intubation Oxygenation. That's what we're gonna talk about. Thanks for taking the time to prepare for the upcoming AIME program. Let's start off with a case, a COVID-19 status unknown patient, and they're coming to your institution and they're sick. Their heart rate's 125, their systolic blood pressure is 90, SATs are 81%, respiratory rate's 36, and they're trying to give them an FiO2 of 100% using a flow-based CPAP mask, but they're agitated and pulling off the mask. Now, if we look back at the beginning of COVID, there was something, weird about 6 liters. As soon as you were, given more than 6 liters of flow, there was something terrible that was going to happen. And that was the primary, trigger point for aggressive airway management and intubating these patients. Nobody really knows where that came from. But what we can tell you is that, trying to give any flow greater than 6 liters with nasal prongs is going to be ineffective. It's just because that's not a device that's meant to deliver high FiO2s. There are different types of nasal prongs you can use that are dedicated higher flow nasal prongs, like the green ones here in this slide. They have a wider bore tubing and can deliver effectively flows of up to 10 liters. Now, there's still institutional variation. At our institution, you can use flows of 15 liters, so you can use a non-rebreather. And we all know that it's not really a non-rebreather at 15 liters without it being considered a AGP procedure. What we do now, and what we really have come is full circle. And what I mean by that is that what we're doing is what the patient needs. If the patient needs oxygen at flows X, then that's what they should get. We should, in every measure, these patients are always going to go, ideally, in a resuscitation area. In a resuscitation area that's ideally a negative pressure room, and you're going to be wearing appropriate PPE. And if you do that, then you don't have to worry about the details. Do what the patients need, give them what they need, and you'll be doing the right thing. So these patients, often when they come into our department, initially they might be just, they might have 5 to 10 liters nasal prongs underneath their non-rebreather at 15 liters per minute. You're trying to do the lowest flow to attain the desired saturation. And then we can do other little stuff that may make a difference in some patients. So, self-proning. Now, what self-proning doesn't mean is you give them, the sheet of paper and say, do this when they're sick. So it does require some direction. It's about changing position and simple measures in terms of changing position. So don't forget this little stuff that might be helpful. The next step, and again, this is to any patient where they're suspected COVID-19, is that you might escalate to using a device that's meant to deliver higher flows and pressurized flows. So escalation of oxygen therapy. And really, there's 2 groups, and there's a lot of terminology mix up. The way we describe there's non-invasive ventilation, which captures CPAP and BiPAP, and then there's the commercial humidified high flow nasal oxygen, whether it's Vapotherm or OptiFlow or whatever you have. So one's a mask-based, tight-fitting mask-based scenario that primarily provides PEEP and CPAP, and the other one is BiPAP, which provides some pressure support and PEEP, and then you've got your high flow nasal oxygen. We used to use these just primarily for diseases for which there was, good literature, so COPD, pulmonary edema, but we've recognized that in broader populations that they might be helpful. So they might escalate to this as a transition in terms of you preparing for intubation, or as a definitive procedure to avoid intubation. So how do you make the decision as to who's going to be tubed or not? And there are these scores that are out there, and there's these algorithms that you can follow. But if you look at the ROX score as an example, it uses saturations, FiO2, and respiratory rate. When you plug them in and it gives you a number that say you should intubate, well, that number is whatever it is, 4.5, blah, 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 4.88, doesn't matter. If you plug the numbers in, they're a sick patient, and I don't need a scoring system to do that. If you've got somebody in respiratory distress who's got altered mentation, usually that altered mentation is because of a rising CO2. It could be because of COVID, and their respiratory rate's greater than 30, and they're working, and they're dyspneic, right? They're struggling. And if you have time and you have access to, you have a VBG and they're a bit acidotic. But if you look at the numbers and sort of say, okay, their SATs are less than 95%, and I'm giving them an FiO2 of greater than 50%, that person has abnormal lungs. They have shunt physiology, and this together is somebody who is going to need to be intubated. If they're not that sick, if they're not altered, their respiratory rate is less than 30, they're not significantly dyspneic, they don't have significant work of breathing, they're not acidotic, then you can use a trial of CPAP or high flow, or if indicated, BiPAP. But all of these patients need to be in a resuscitation room where you're going to follow them closely, because they're going to turn around or not turn around in the first half hour to an hour. So they're going to be in the same room as when they had a non-rebreather on and some nasal prongs on, and then escalate them to CPAP or high flow nasal oxygen, and then escalate in that same place for intubation if you need to do that. So in this scenario, we're going to take us to the next step in saying, listen, this has failed. We've made a commitment. This person needs to be intubated. So let's look at peri-intubation oxygenation for this sick patient. Now, checklists have gotten a bad rap over the past little bit, and they've gotten a bad rap. It doesn't mean the literature has proven something, because it really is poor literature, and not necessarily looking at the right outcomes. In my view, the purpose of a checklist isn't exactly the same thing as what it is with the pilots that we always refer and have reference to, but in some ways it is. It's not forgetting the little stuff. Right? So, and it is the little stuff that makes a big difference, whether it's positioning your patient, right? It's remembering to have waveform capnography on for all of your patients. All of your patients. You're going to have a SAP monitor, ECG probe, blood pressure, waveform capnography for every patient. So we're going to remember that from the beginning. We're going to position our patient, right? We're going to have the head of the bed up, and we're going to have them in sniffing, right? So ear to sternum, as we've talked about and we'll talk about and reinforce, is just an endpoint for sniffing, right? So they need to have some flexion and extension for you to facilitate laryngoscopy and intubation, right? They might need ketamine facilitated cooperation, otherwise referred to as DSI. I don't like the term DSI. I like the concept. We've been using it for years. Is that facilitated cooperation for whatever it is, putting in an NG tube, administering oxygen, reducing a shoulder, right? In this case, it might be ketamine facilitated cooperation so that they will tolerate your pre-ox scenario. And then we're going to use always two sources of oxygen. We're going to reinforce this in the workshop. If they've got normal lungs, then you can use an open type system. All patients are going to have nasal prongs on, right? Nasal prongs under. When somebody is not sedated, they don't tolerate more than 10 liters very well. It can be irritating and cause some agitation. So that's why while they're awake in that, I will limit it to 10 liters. You can crank it up to 15 liters once you put them to sleep, if you remember that. But after 10 liters, they can get a little bit agitated. So you're going to have your nasal prongs on underneath your non-rebreather. And the non-rebreather, yes, it goes up to 15 liters, but it can go up to much higher than that. And the term we use is flush rate. What flush rate means is that we're cranking up the dial beyond that 15 liters. It'll make a hissing sound like a plane's about to take off, and you'll be able to deliver upwards of 60 liters per minute. And the purpose of that is to use that when the patient has high minute ventilation. So when the respiratory rate is high, and they've got big tidal volumes. They might be breathing at 30 liters per minute. You're only providing them with 15 liters per minute with your mask, and they're going to entrain additional flow and dilute that FiO2. So two sources of oxygen, right? If they've got normal lungs, you can just use nasal prongs and conventional nasal prongs and a non-rebreather. If they've got abnormal lungs, your sats are under 95% in this situation, or under 93%, you have to recruit stuff. You have to provide some pressure, and you can do that with a homemade system such as your BVM with a PEEP valve and a pressure manometer, or continue to use a non-invasive ventilator. Have nasal cannula on underneath, and the reason why you're doing that is so that you'll continue it through the process and have it for apneic oxygenation. Give them a fluid bolus. I know there's some literature that has initially said that it wasn't effective, but in the volumes that they were given, it wasn't really much of a surprise. So if they need something, give them something. And then if their shock index, their heart rate's greater than their systolic blood pressure, then give them start some norepinephrine. This is the time to fix your shit, right? Resuscitate your patient. If you rush into intubating the patient, you're going to run into problems. You're not going to have the time you need to perform the procedure. And if you don't remember the little stuff, you're going to run into trouble, and that's going to affect your ability to perform. Okay, so pre-intubation oxygenation. Who's in the room? In our place, we have a gaggle of people. And I know many of your institutions, you're not going to have many people, right? You really don't need more than 3 people. You can do it with 2. Ideally, your assistant is somebody that's familiar with airway management. And if they're not, this is when your teams need to do that, right? They're cognitively offloaded. They'll be able to sort of see things that you don't see. And then having somebody else that's going to administer the drugs, who's going to be your timer in the room. So whether it's another colleague, whether it's a nurse, whether it's a paramedic, this is what your team involves. These patients in respiratory distress, want to sit up. So you're going to do your pre-ox without grabbing their jaw in this situation by applying the mask to the face. And what you're looking at in this scenario, we're looking at seeing what's going on the monitor, right? And the thing I pay attention, yes, to their heart rate, and we check their blood pressure, which is cycling every 1 to 3 minutes or 3 minutes, at this point. What I'm looking at is the waveform capnography here, because what that tells me about, that gives you breath-to-breath information. Your SATs is a reflection of what's been going on, but what gives breath-to-breath information is that waveform, and it tells me about my mask seal, whether I've got a good seal or not, right? And you're gonna learn what a normal shape of a waveform, that top hat appearance, right? So you're gonna that's what you want to look at and get used to. What we need to remember is good SATs don't mean safe apnea. Right now, you all have SATs of 100%, but you are not going to be safe from a point of view from an apnea time. Saturations tell you nothing about oxygen stores. Right now, if you were to stop breathing, how long would it take for you to critically desaturate? Right? How long would it take you to critically desaturate? Well, it'll be about 80 to 90 seconds, right? Because your stores in your lung are not adequate. So let's talk about that a little bit more. And just, again, to reiterate, if your SATs are at 90, and we think 90 is great, that's an A in school, that's awesome, right? At 90, if I'm not replenishing oxygen, right, and I paralyze this patient as part of an RSI, the SATs are going to fall by 1% every 2 seconds. I'm going to say that again, 1% every 2 seconds. And there's somebody in the room whose dedicated job is to count those as they drop, right? So again, SATs don't tell you about safe apnea time. Right now, you sitting wherever you are, you have SATs of 100%, you're breathing room air, but you only have about 400 mils in your FRC of reserve. Your PO2 is 100, and your SATs are 100%. You've got normal lungs, but how long will it take you? desat when we do an RSI in somebody that hasn't been pre-oxygenated? As I said, you'll drop to what we call critical desaturation, under 80%, in about 80 seconds with normal lungs if you haven't filled that reserve. So our purpose of pre-oxygenation is to denitrogenate the lungs, to take that 400 mils and turn it into 2,500 mils. And all we have to do is apply 100% oxygen as long as the flows are in excess of what their inspiratory needs are. And in that situation, the PO2 is going to go up to 60. Your SATs don't go above 100%, right? So you can have a PO2 of 100 or a PO2 of 600. The PO2 of 600 was what gives you time. Now, we don't measure that, right? So the only thing we measure in this situation is the time of a high FiO2, right? And how long is that? That's about 3 to 5 minutes. So in this situation, how long would it take? Theoretically, from mathematical modeling, it'll take upwards of 8 minutes if you've totally denitrogenated a patient before they would critically desaturate. That's not in real life. The bottom line, it'll be more time. Now you take a sick lung, and they've got pneumonia there. And with that pneumonia, what it is, it creates a baby lung. Right, so because that alveoli are consumed by pus and crap, and the surrounding ones are collapsed, you've got less lung, you've got less FRC, and we've got shunt physiology. And what all that means is that you've got blood coming back, deoxygenated blood, trying to get reoxygenated, and they're passing by these alveoli that don't have any room. They're full of pus, so they can't reoxygenate the blood that would happen normal. That's what shunt physiology is. Let's take somebody that like our patient. Let's say we put them on CPAP, and their SATs are 85%. That's the best we can do. How long will it take for them to desat once we remove that mask to do laryngoscopy? Seconds. About 2 to 3 seconds. It's going to happen immediately. And when it happens immediately, again, it's falling. You're going to be stressed out. You're going to hear that tone fall, and your ability to perform is going to be affected. I want to take this a little bit further. I think this is an excellent way to view this. This is a graphic by Casey and Semler, who have done some tremendous work. And they've broken down peri-intubation oxygenation into 3 phases. Phase 1, which is the phase we've talked about, the pre-intubation phase. Phase 2 is once you push your drugs. And phase 3 is during laryngoscopy and intubation. Here they've got them divided up into equal segments, but they're not equal segments. The biggest and most important segment that's going to prevent or decrease the chance of having desaturation during laryngoscopy is what you do before you give drugs, right? It's not really all dependent on those nasal prongs that we have on during laryngoscopy. It's what happens in this period, that 3 to 5 minute period, that phase 1 that we've already talked about. So max that out in that scenario. When we push the drugs, the respiratory drive goes and they become apneic over that period of 45 to 50 seconds after they've had their induction and their paralytic agent. Right? But their saturations will remain, right? You will lose their waveform because that's breath-to-breath information, but their saturations will remain there, and they'll remain 100% if you've pre-oxygenated your patient. Remember, saturations, there's what's called pulse-ox lag. There's a delay in what you see in the saturations peripherally from what's happening centrally. Right, so the saturations will fall later and they'll rise later than what's happening in real time. So phase 2 is when you give the drugs. Phase 3 is apneic oxygenation, and I've got 30 to 90 seconds. Most of the time, I'd say 90% of the time, an uncomplicated laryngoscopy and intubation should take less than 30 seconds. And you're going to do difficult airway drills to do it in under 30 seconds, to do all those maneuvers in under 30 seconds to get that safe apnea time. And that's not going to make you hurry up, right? You're going to be able to do that comfortably. During that period of time, we're going to still apply oxygen, right, through nasal prongs. But the reason why many patients aren't going to desaturate during that period of time is because it's uncomplicated and you're able to intubate quite quickly. So phase 1, just in summary, 100% FiO2. If they've got normal lungs, you can use your non-rebreather. You just crank that up. And you can go to flush rate oxygen, right? Just go take that ball above 15 liters and you'll get, as I said, anywhere from 40 to 60 liters off of our regulators in North America. And you're going to have nasal prongs underneath it, 10 to 15. I tend to use 10 initially because some patients will get agitated by higher flows, but 10 to 15. And the purpose of that nasal prongs is, yes, to give you added flow, but also keep it on throughout the procedure, throughout phase 2 and phase 3. And you need time, right? So you need at 3 to 5 minutes to denitrogenate the patient, to wash out the nitrogen, because remember, 21% oxygen, the majority of what's in the lungs that you're breathing right now is nitrogen. Now, for the abnormal lungs, the baby lungs with shunt physiology, what we need to do is recruit alveoli. So we're going to have our 100% FiO2. And again, what we need to make sure is that our source flow is greater than their inspiratory flow, right? So if we're given 15 liters and some nasal prongs, under there of 10 liters, they've got 25 liters of flow. Some of these patients that are really dyspneic and tachypnic, they'll have flow rate needs during inspiration of between 30 and 60 liters per minute. So again, if you don't meet that, what's going to happen is they're going to entrain Romaire and dilute the FiO2 in that situation. In abnormal lungs, we need to manage shunt, and that means is that we need to provide pressure. Either pressure, at the end of pressure during expiration. All that does is, just think of it, if you're breathing against sort of the spring-loaded PEEP, right, what that does is there's this backwards pressure that goes back and distends the alveoli and recruits alveoli that it might be collapsed around the areas of the baby lung and the pneumonia, to recruit them, to open them up, right? So they're going to now be able to help you out in terms of gas exchange, right? Sometimes you need to do pressure support and give them inspiratory support. That combination of inspiratory support plus PEEP is BiPAP. If you're just doing it with just PEEP, it's essentially CPAP. And these patients, again, are spontaneously breathing. And you can do it two ways. Your homemade version, and your homemade version is just your BVM with a PEEP valve, a pressure manometer, and other gear, right? With nasal prongs on it and flows that we'll talk about in a minute. And you've got essentially a machine, right? To let them breathe spontaneously with a good seal, look at their waveform, and you're giving them CPAP. You can give additional breaths, right, with your BVM. The problem is if somebody's got a respiratory rate of 30, it's really hard to accurately give those breaths. So if they've got a high respiratory rate, now I've got to give them inspiratory support, either give it every second breath, and somebody's got to really be concentrating, or ideally it's triggered by a mechanical ventilator, a BiPAP machine, a CPAP machine. That's the safest way to do it in that scenario. All right, so phase 1, phase 2. Phase 2, what does that mean? What are we talking about in that situation? Phase 2 is that transition to apnea, right? We've given our RSI meds. What we're seeing is a nurse on the right. What they're looking at is they're about to tell me when that 50 seconds is up. We're keeping them upright, and then we're going to take them down to a reverse Trendelenburg position, and as their airway collapses, right now their airway was open, you've got to get behind there and open their airway, do a jaw thrust at this point when they become not supine, but in that reverse Trendelenburg, or head up 25 by 25 degrees, and place an OPA in that scenario. And then what are we going to do? Well, we have to wait before we do laryngoscopy. So what do we do when we wait? One is we could do nothing, right? And nothing meaning nothing active, not squeezing the bag. And this is what we call apneic CPAP. And what we're using is our device. And even when they stop breathing during this period of time, we can provide CPAP as long as we have enough flow in our system. And what enough flow in our system means this. You've got our super BVM that you see here, which is our mask, viral filter, waveform capnography. We've got a corrugated tube. And that corrugated tube there is just so it's not unwieldy and tall, this whole setup. We've got our BVM with a PEEP valve and a pressure manometer. Sounds complicated, but it's not, right? There's flow of 15 liters coming through our BVM, right? And we don't need to go to flows higher than that as long as our reservoir bag's not collapsing. We've got 10 liters through our nasal prongs, and our nasal prongs in this situation are giving enough flow inside the mask to activate our PEEP valve, and our PEEP's dialed in at 10. So 10 a PEEP, 10 of nasal prongs, and 15 liters through our BVM. And look what's happening here. So I'm going to do an aggressive jaw thrust. Here it is, an aggressive jaw thrust with an OPA, not bagging the patient. Look at the recruitment that's happening. I'm not squeezing the bag here, right? So this is apneic CPAP, right? You can do that as long as you've got this system set up, which is pretty basic and everybody should have access to. Or what we're going to do, and this is probably the right thing to do in general, is to do gentilation during that phase 2. During that phase 2, when the RSI drugs are doing, and you're not just, you're not going to aggressively do this, you're doing gentilation. Gentilation is a term Ross Hoffmeyer from South Africa and Max Sorbello from Italy coined the term, which I love it. And what that means is they're not just going hard and fast, right? They're gently administering. They're looking at the pressure manometer, not going over 20, so that they're not going to fill up the stomach with air. They're looking at waveform, right? And what you see in that picture to the left at the bottom is what a normal waveform would look like. What you're doing now, and the advantage of doing this technique as opposed to the apneic technique, is that I can check my mask seal. I can look there and see my breath-to-breath information with waveform and say, I don't have a leak, right? I don't have this variable amplitude, right? Almost sinusoid type of variable amplitude, which tells you I've got a leak. If you do that, it tells you I've got to adjust, right? I might switch from a one-person technique to what you should do always is a two-person technique, right? So we're just using that gauge. We're keeping an eye on things. We're paying attention with the pressure manometer. We're paying attention, looking at the monitor, not necessarily for sats, but waveform. And we'll make adjustments as needed here, right, in that situation. I'm just going to show you about recruitment. So, we tend to, when somebody's sats are low, we tend to overventilate them, right? But I want you to look here when you've got a PEEP valve on. We're going to put a PEEP valve on, how many breaths it takes to recruit, okay? So when we don't have a PEEP valve on and we're bagging the patient, and this is a PEEP of 10, 1, 2, really 2 breaths, 3 breaths. You after that, after 3 breaths and an FiO2 of 100% and adequate flows, you're really not affecting their oxygen much. You're just affecting their CO2. I'm not saying during that period just give 3 breaths because that's really hard. What I'm saying is don't overventilate the patient. Limit it to 10 and be careful with it. Gentilate them, right, during that period of time. And what we know is if we do this during this period of time, the focus is why didn't we want to ventilate them during that induction period? We didn't want to do it because we were going to cause aspiration. That's been the concern over history. And cricoid pressure and all of the debate there, all of this concern. I think it's really come down to is cricoid pressure might have a small place, but what's more important is don't overventilate your patient, right? And if you do it safely and gentilate them, there's really no increased incidence of aspiration, but what there is a decreased incidence of severe hypoxemia if you ventilate them gently during that period of time, paying attention to the monitor. You're going to have less severe hypoxemia, right? So that's phase 2. Phase 3 is about what do you do in terms of leaving the nasal prongs on during this. If you've done all of the things up to this point, probably the added value of the nasal prongs is limited, especially in normal lungs, if you execute your procedure quite quickly. But it is reasonable to leave nasal prongs on during that period of time. And what you're doing is replenishing the oxygen. What we have to remember, as soon as we take the mask off that face, we actually de-recruit. We lose all of that recruitment. So providing additional oxygen and working safely and quickly is important to do during this period of time. So apneic oxygenation, again, it's during this period of time. What's the difference? And this is kind of painful for me. You can't see the nasal prongs that are on. Is just during this period of time, we're continuing to provide oxygenation. I'm doing all the things I need to do to optimize the laryngoscopy, doing a head lift. I'll reach around, do ELM. But apneic oxygenation is during that phase 3, during when we're doing laryngoscopy and intubation. Most of the time, what we're going to do in that situation is, again, what happens is the masks come off and we're going to leave our nasal prongs on. And this is why people like leaving it at 15 liters or flush rate when they become supine, is that, you know, you don't have to remember it at that phase and reach back, but nasal prongs are already on. And again, your goal is to execute this procedure in less than 45 seconds. And again, you're going to train to do it in less than 30 seconds. If they've got abnormal lungs, right, as soon as we take off their mask, the pressure, they're going to de-recruit those lungs. Sometimes in sick lung patients, what I'll do is I'll spend a little bit more money on them. I'll have the mask on and I'll have the humidified high flow on their forehead. And I'll drop that down during laryngoscopy, especially if I think it's going to be a difficult laryngoscopy, a difficult airway in that situation. This is what happens. This is what I mean by de-recruitment. So what de-recruitment is. So what you'll see, recruited, remove mask, boom. Right? So that happens immediately. So what we want to do is continue applying oxygen. So how does this apneic oxygenation works? I'm going to oversimplify it. What we're doing is providing high flow nasal oxygen, provides some turbulence and higher concentration and pressures at the nasopharynx level. And because of the fact that CO2 is entering the alveoli at a lower rate than oxygen's leaving, it's running from a lower concentration to a higher concentration, lower pressure, a higher pressure to a lower pressure. And that happens passively. Right, so they're passively getting oxygenation during that by their nasal oxygenation. So phase 1, phase 2, and phase 3. Now, we can't exclude the fact that other things matter. What we've been doing right now, this is how do we, for safe apnea time, how do we increase the volume of available oxygen? That's what this has been about. But we also have to address rate of oxygen consumption. How do we decrease this? For you and I, as we said, let's say you're a 70 kilo person, you're pre-ox and you've got normal lungs, and we do it for 3 to 5 minutes. It can take 8 minutes before they critically desat. In children, it's less because they have their FRCs smaller, their consumption's higher. In obese patients, same thing, less reserve, increased consumption. And ultimately, in the person who's really sick, how long does it take for them to desaturate? We know that, as I said, it'll happen almost immediately if they're already starting from a bad place. Sats in the mid 80s, right? They are what we term apnea intolerant, and that's an important term to recognize. So good sats don't mean safe apnea. What we do need to do is recognize that it's not just about oxygenating the blood. We need to push that blood around to where it needs to go, the brain, the heart, and the tissues, and that type of thing. So what we need to do is correct underlying shock states, right? If they need to be resuscitated from a sepsis point of view, we need to give them fluid. If they early use of norepinephrine, again, starting that even in the pre-intubation phase and then continuing it. But if they're disease mandated that to begin with, you're going to address that. If they need blood, you're going to give them blood. If they need, something splinted, you're going to splint them. The principle is that you need to resuscitate them in order to really get the effect and push that oxygen to where it needs to go. So resuscitate before you intubate.